evaluation is very difficult, but still we need to explain the course of the disease to the parents first, because their anxiety is going to come to the child also. The child initially may not be bothered, but later as the parents get anxious about it, the child also gets affected. We can counsel them about the course of the disease, and that they need a lot of patience for treatment, and to see the evolution of the disease in the child, how it is going to evolve.
This is a big issue actually. Dr. Bhumesh, you want to make any comment on this?
Counseling? Yeah, the counseling part in the pre-teens and teens is different. In the pre-teens, we have to give counseling to the parent, not to the child.
Yeah.
And we need to explain the benign nature of the conditions, non-infectious nature of the conditions. And at the same time, we need to explain the natural history, whether it is a segmental or non-segmental. Based on that, we have to explain the natural history, and we have to look for any associated autoimmune disorders are there or not. And this is the way. Whereas in the teenage group, adolescent group, they're very, very difficult to counsel those because the peer problems in the schools is very, very, very high. Even that stress itself is responsible for that aggravation of that particular condition. So you have to counsel whole family, along with the child and the father and mother and whole family. The counseling should be given to the whole family and explain the benign nature and the natural history and the pros and cons, everything we have to explain.
So now this is going to be a real debate. So I will be going to ask every panelist like how they approach like a 6-year-old child with rapidly progressive vitiligo, because here we have a dilemma: to go with an aggressive immunosuppressive treatment or to wait and watch with a conservative management. So yes, I can start with Dr. Bhumesh first because he's first on my.
Yeah, the thing here again, it's a lot of debate because the vitiligo in especially non-segmental, it is a progressive disease and the progressive destruction of melanocytes. So the under treatment always it will damage to the child, like atopic dermatitis and psoriasis in that way. So that's why that the 3-year child we have treated with initially in the oral mini pulse, and we could stop the progression of the disease. That is my perspective. The personally not much experience. I need other panelists also. But one thing we need to sensitize, it is a chronic progressive destruction of melanocytes. That we have to keep it in mind.
Yes, Dr. Vikrant, how do you approach? Like you start with...
I always feel vitiligo may be medically benign, but in Indian situation, the impact is so severe that you cannot consider it as a benign disease in Indian situation.
Yeah.
That is my personal strong belief. So I believe in aggressive treatment of vitiligo. So fortunately, most of the time, vitiligo less than 5 years of age is very uncommon. So usually you see 5 years and above, and there I have probably little inhibition in starting immunosuppressant.
Yes.
So I definitely prefer giving immunosuppressant for vitiligo. Even in
come to the choice of immunosuppressant later, but just Dr. Renuka, your opinion, like you prefer?
Definitely treatment needs to be started at the early stage. But whether we will go in for phototherapy to control the activity and see if the child doesn't respond, then going for immunosuppressives or going for systemic corticosteroids early is probably an individual opinion. But if it's a 6-year-old child who can stand in the phototherapy unit, probably I'll try for phototherapy to control for a few months, and then immunosuppressives if the disease activity still doesn't come under control. Yeah. But definitely treatment has to be started early.
Lakshmi ma'am.
My approach is it's a very fast progressive. Definitely, I go for a combined therapy, that is systemic therapy as well as narrowband UV therapy, the light therapy also. Definitely, because it affects the parents and the child like anything. We should do the treatment. I usually do combined treatment.
Okay.
Above 6 years.
In fact, my approach is, I have been treating vitiligo for the last 40 years. There's a paradigm shift in my management of an patient, 6 years old, aggressive patient. 40 years back, I would not treat. I would say, no, koi baat nahi hai, ye cosmetic problem hai. But today, I don't think that way. I think vitiligo in a person who has got aggressive disease is a systemic disease right at the outset. But I would differ that I would not, I would restrict phototherapy for first 2 to 3 months, because I think in some of the patients, phototherapy may cognize and increase the vitiligo. So I would first of all stabilize the disease with immunosuppression. And what has been best, your approach of giving low dose of weekly OM pulse. That is one of the, that has made the drastic change in my approach to the treatment of the disease. Because with higher OMP, we would get patients, we would be able to restrict the patients, but after some time, we would get steroid side effects, and we had to stop the steroids, and there was a big problem of a flare-up. The lower dose of OMP, it has worked very nicely. Phototherapy, since I don't use phototherapy, but I certainly use photochemotherapy. After first 3 months of stabilizing the disease with the corticosteroid, mainly in this age group, I would shift, I would add photochemotherapy after 3 months, and results are quite good in these patients. Yes, everyone may not improve, but even despite immunosuppressive, if a patient is still going down, I would like to investigate him for all the immunological profiles: pernicious anemia, Addison's, diabetes, thyroid. Because there is a problem that whenever we are giving the proper therapy and still the spread is more, we have to be careful. We have to be on the watch.
Yeah, Dr. Slim, what is
Yeah.
your protocol?
My approach would be like, if it is below 6 years, it's really the topicals followed by Excimer is my first line protocol. If it is above 6 years, if it is very, I mean, the progression is quite fast, I might start with a low dose oral mini pulse or a very short time steroid, just as a bridging treatment, and further I would go with your regular phototherapy along with the topicals.
Yeah.
Unless otherwise you require a immunosuppressive like a cyclosporin or a azathioprine, I would prefer that in a child rather than going for a long-term steroids.
Yeah, Dr.
Because
Sumesh.
cyclosporins has been used in atopic dermatitis in children. There are a lot of well-documented studies. So a very low dose pulsed dose of weekly pulse dose of cyclosporin would be a better option than going for a steroid beyond 3 months.
Yeah. Yes, Dr. Sumesh.
Yeah, so that's a very important question, and that's always a dilemma in our day-to-day practice, because when a patient comes, first we have to determine what is the type of disease. If it's an acrofacial disease, means all the lesions which will develop on the exposed sites will never go back, particularly on the fingertips and palms and soles. So that will bring a lot of stigma to the child. So we have to hit early and hit hard. But if it is a segmental vitiligo, we know that it is a disease. And I have seen segmental vitiligo, complete reversal of segmental vitiligo with monotherapy with topical tacrolimus. So we should not treat very aggressively. Non-acrofacial, non-segmental disease is again sometimes when it is predominantly on the covered sites, on the hair bearing area, where we know that phototherapy should work. So we always strike a balance, and I generally start with if I see acrofacial disease, I start with mini pulse, but I give it for the short term and then rapidly shift to the skin directed immunosuppression, that is either phototherapy. Now I use a lot handheld photo lamp, narrowband UVB lamp, so that child doesn't need to visit hospital every day, every now and then. And then I often use tacrolimus under occlusion. So over the years, I have shifted the maintenance therapy on skin-directed immunosuppression and melanogenesis stimulation, rather than giving prolonged immunosuppressive. Because there are two ways we can think of. One is that if we treat the child with aggressive doses of immunosuppressive agents such as azathioprine, methotrexate, cyclosporin, this is a growing age and when the immune system is still immature. And when we trim a growing tree, the tree will never be fully developed. Similarly, if we suppress the immunity at a very early stage, when there is immune system development is going on, then it may have a far and very damaging effect. And we don't know what happened in the later life. There may be permanent immune senescence. So we have to be very careful. I have stopped giving non-specific global immunosuppression in these children. But I have tried um, some biologics in some of the children who can afford, and I found that they are well tolerated and they are safe and they are more targeted. So now I'm shifting the approach, skin directed immunosuppression, but initial control using mini pulse or initial control using JAK inhibitors if
Yeah.
patient can afford.
So I think all of us agree on this point. If it's a rapidly spreading like acrofacial, so we need to go for certain immunosuppressive therapy, maybe of your choice. We will be discussing, and there are many questions on which is an ideal immunosuppressive in such an age group. So to my mind, for treating vitiligo, we have two goals. First is stabilizing, then repigmentation, and then finally for completing the repigmentation, we have a role of surgical modality. So we'll be try to discuss quickly. So because as we are already quite late, so just I think we go by selective now. So antioxidant, because huge in vitro data is there for their efficacy, but the clinical translation is not that good. So any panelist who prefers antioxidants, first we can ask who prefer antioxidant as a part of treatment.
Yes, I do use antioxidants. I use antioxidants in vitiligo quite frequently. I give a wash of period also in between, but I use them because we know that there's a stress and it may be past a polypodium leukotomas. I have found it very, very effective. This is a good drug and I use it very quite frequently. I have found it very effective. And in fact, after 3 to 4 months or 5 months of this initial with the corticosteroids, I taper after 3 months. By 4 to 6 months, I stop the steroids. Patient is on, as Dr. Somesh said, skin-directed topical this immunosuppression plus maintenance therapy with polypodium leukotomas. It works very well.
So anyone who is fond of prescribing antioxidants as a topical therapy?
It is like, as we say that even though there is no direct studies to show that in vivo, whether it's really working, but all the in vitro studies have shown that these antioxidants do have a role. And second thing is that we also do have the vitiligo is a disease where there's a lot of oxidative stress. So even though there is, if it doesn't work as a monotherapy, along with your regular treatment, an antioxidant should also work synergistically by reducing the oxidation stress there. So that is why I always add on one of the antioxidant along with the regular therapies, not as a real first-line therapy.
Yeah. So anyone against using antioxidants, Dr. Sumesh?
Yeah, I never use antioxidants because it adds to the cost. Patients keep on taking, and in spite of its theory, the oxidative stress theory in existence for decades now, the clinical trials after clinical trials have failed to show slightest effect on the progression of the disease, because we have to question the efficacy of an agent which is available for many decades, but still there is a doubt. You are asking a question whether it works or not even 30 years after the introduction of oxidative stress theory in vitiligo. That itself is an indication that in clinical practice antioxidants do not work as of now, unless tomorrow you bring a randomized control trial clearly demonstrating the efficacy, then it's a different story. But even topical oxidative antioxidant, or like for example Shelduter, she demonstrated.
We know it's not effective.
On a topical note, I really don't have faith in topical antioxidant, but systemic, I think they work.
Yeah, so this is like, I think to my mind, when we are prescribing antioxidant, we should know what is our aim. So it will not going to act like immunosuppressive. So they are helpful in a way to my mind. So they can be safely given because cost is one factor, but looking at immunosuppressive, so they are very, I mean, safety profile is huge advantage with antioxidant. And probably they have a role in once we have given stronger immunosuppressive, we can just shift to a safer modality like antioxidants, which is quite safe that way as compared to the immunosuppressive. So now coming to the main our part, which as of now all of us are using OMP. So now there are few questions also. Which is your preferred agent? I can start with Dr. Bumesh, like your methylprednisolone, vitamethasone, dexamethasone. Which is your favorite molecule?
My favorite is dexamethasone.
Okay. So what would be the doses
The cheap and easy. The dose is 0.2 mg per kg per week, 2 times in a day. The 2 days in a week.
Yeah.
So that means 0.1 mg per day.
Yes, we follow the same protocol, 0.1 milligram of dexamethasone, 0.1 milligram per kg of dexamethasone.
Per day, 2 days in a week.
2 days a week, yeah, 2 consecutive days per week. So some prefer methylprednisolone in children less than like 6-year-old. So anyone who prefers other than dexamethasone? Yes, Dr. Sunil?
Yes, I prefer short ones. I prefer shorter ones, shorter acting ones, because the dexamethasone has a half-life period, and 2 days therapy would execute its inhibitory effect for 4 to 5 days, 6 days on the HPA axis when we give dexa. With prednisolone, it does not have so much of a longer half-life. So by about 2 to 3 days, HPA axis is released. So we may not achieve good suppression of HPA axis by using a shorter acting steroid. I personally prefer to use prednisolone, simple prednisolone, not even methyl prednisolone. I use simple prednisolone, and the dosage is simple: 0.5 mg per kg body weight per week, per day for 2 weeks a day, for 2 days a week. That's it.
I use betamethasone. That's dose depends on the severity. Okay. Maybe 0.1 milligram or sometime even less if it is not very aggressively spreading. And sometimes for a very rapidly spreading disease, I do use daily steroid for a month.
So, Madam Lakshmi, your preferred?
Yeah, I use both dexa and beta both.
Okay.
Sometimes betamethasone, sometimes dexamethasone.
Dr. Renuga?
Betamethasone. Betamethasone in the dose of 0.1 milligram.
Dr. Slim, your preferred?
I feel I go for the newer ones like the methylprednisolone as well as prednisolone, because it's less of mineralocorticoid activity, more safer, I think.
And Dr. Sumesh, you prefer?
Yeah, we prefer betamethasone, because just I want to highlight that the half-life of dexamethasone and betamethasone is 36 to 72 hours. So virtually, even when we are giving 2 days, the effect lasts 4 or 5 or 6 days, even a week. So it's a kind of daily therapy. It's an not a pulse therapy. It's an intermittent therapy, but it still give 2 or 3 days gap. So prednisolone, methylprednisolone have a very short half-life. So we reduce the side effects, but at the same time, we also reduce the efficacy when we replace betamethasone, dexamethasone with prednisolone or methylprednisolone. So we have to be careful. If we are replacing in a very rapidly progressing disease, then it in the form of pulse, prednisolone and methylprednisolone may not work as well as betamethasone and dexamethasone.
Yeah. So dexamethasone in these days now known as COVID drug, because one of my patients now called me and said he's already taking this. Why you have prescribed me this COVID drug? He's using this dexamethasone. So this is getting famous as a COVID drug. So any experience with the methotrexate? Any panelists? So we found it.
Yeah, I use in children. Suppose if the patient is not responding to oral methylprednisolone, oral prednisolone mini pulse, I shift to methotrexate.
Yeah. So any
1 milligram per kg body weight.
Yeah. Yes, Dr.
I use methotrexate, but not very happy, not found to be really very effective. My preference is azathioprine, but when azathioprine is somehow maybe is not patient is not tolerating, in that situation, sometimes I do use methotrexate, but I really don't think it is a really very great, is very effective.
Yeah. Any other comment on methotrexate?
And if I use it, I used to wean the steroids for 3 to 4 months. I use steroids. When I'm weaning the steroid from 4 months onwards, I will introduce methotrexate, because methotrexate has a good action to maintain the disease. We have to realize I don't use methotrexate to induce the remission. I use it to maintain the remission. It acts very well without the long-term effect of steroids. In some instances, whenever I feel there might be some rebound after I stop the steroids, methotrexate acts very well.
Yes, I agree with this, because if you're looking at its mechanism of action, it's a slow to act. So
Yes.
because all, I mean, as a dermatologist, so all of us, like, we have used OMP. So when we are trying some new drugs, so we expect it to be effective that way, and we just lose our patience, say, oh, this is not effective. But in vitiligo is such a interesting scenario. So every drug act very differently. So you have to assess the drug accordingly, not as a comparative to any other
Yes,
agent.
yes, yes.
This has very good, in sometimes I've seen a very resistant patches showing pigmentation. So this is like we are working on its mechanism of action. Sometimes in combination with phototherapy, very resistant patches, they do show repigmentation, but it's very slow as compared to OMT or other immunosuppressives.
I have found this methotrexate, it gives excellent results when combined with calcipotriol, especially on the acral areas, because acral areas we may not be having that much effectivity of calcineurin inhibitors or
We will
steroids.
come to topical just shortly. Before that, phototherapy is mainstay because of shortage of time. So any specific lab tests as per protocol, is Dr. Bakaya sir, if you go for some lab test before subjecting patient to phototherapy?
Yes, I go for ANA testing. I do. It may be a small child also. I do ANA, I do CBC, I do hepatitis profile, because the way we give it in psoriasis, the same way we have to give it in vitiligo also. I do take care. And so I'll tell you, I have been using not phototherapy, I have been using photochemotherapy, but not for children. I never use topical povasol I may use for children, but POVA I don't use below 12 years. But I have been using, I have done my house job from Srinagar. In 1980, I have done my house job. We had a phototherapy machine even in 1980 at that time in Srinagar. So I have had good experience of POVA. But of course, I don't use POVA now. I use povasol because I don't have a setup where I can give phototherapy. But it works quite well.
Yeah, Madam Lakshmi, in your experience, what is the smallest child you have taken for phototherapy?
It is 5-6 years age, 5 years of age child also we have sent inside. Mother will be standing outside the thing, like.
As such, there is
so
no, like
the parent will be there.
Yeah.
Parent will be there near the apparatus. So child will be inside. Door will not closed completely.
Yeah.
It will be like that.
Yeah. So Dr. Salim, your experience?
Targeted phototherapy would be another option for even younger children than this.
Yeah. So exam probably, if some focal patches, probably
exactly
that role of phototherapy. So we can have like other immunosuppressives like azathioprine, mycophenolate. So any panelists want to add on this other
Yes, I think azathioprine I use almost very regularly in most of my patients, and it's a very good drug for the treatment of vitiligo. That is my experience, because you can't use steroid for a long time. Steroid, no doubt, is very effective, but you can't use it for a long time. It's vitiligo follows a very chronic course. You can't use steroid for that long. So azathioprine, I find, is a better drug for long-term use of vitiligo. And there are good number of studies where it has been used in the very young children for atopic dermatitis. So I think, can I share some of my photographs with
Sure.
azathioprine results?
Sure.
Do you do the TPMT before starting?
No, I don't do that. But because without TPMT, I use less dose. My starting dose is usually 1 milligram per kg, not more than 1 milligram per kg body weight. And it shows a very good improvement. It's slow to act, but yes, it gives a very good improvement. And you can see these results. And I think I'm very happy with this. So it's a very good drug. I'm very happy with this drug. Even so-called unilateral vitiligo also, it works. So it's a, no doubt, I'm very happy with this. And I feel it reduces my requirement of steroid, and it has given most of my patients a very good, very satisfactory results.
Yeah.
So I'm happy. I would strongly recommend the use of this drug for the treatment of vitiligo.
But I am not comfortable with other type in pediatric age group. The reason behind, I am happy with methotrexate. If you compare with methotrexate and cyclosporine, azathioprine, all three have immunosuppression and myelosuppression. Whereas cyclosporine is a powerful immunosuppression, negligible myelosuppression. That's why it's a crisis buster. Whereas methotrexate, it is a medium, the maintenance immuno and myelosuppression, whereas azathioprine, it's a powerful myelosuppression rather than immunosuppression. That's why in adults it's okay, but in pediatric age group, I little bit discomfort with azathioprine, but I am happy with methotrexate. And in crisis buster, of course, cyclosporine.
So this is like a future, like we are moving toward the targeted immunosuppression. So JAK inhibitor follows that one line. So we are future very interesting modalities in the line where we were targeting heat shock protein 17, which will be like a sort of immunotherapy. Patient will be given like a injection of DNA mutation. So it's on the phase 2 trial now. So that is the future of vitiligo therapy, which can change the immune response in vitiligo. So this is a new other molecule, so I will not touch upon today. So now we move on to our repigmentation aim. So with the topical, so there is some question also, like I will just quickly ask every panelist, which is their favorite topical steroid. Dr. Bhumesh, what is your favorite typical topical steroid for vitiligo?
Mometasone, sir.
Ma'am Lakshmi?
Mometasone only.
Okay, so Dr. Bakaya, sir?
Sir, about 12, I would be happy with clobetasol, but below 12, mometasone will be very good. Or desoxymetasone, what is the newer one? I use that.
And Dr. Slim?
I use more of fluticasone, sir.
Fluticasone is also good.
Fluticasone along with tacrolimus is my regular combination in a pediatric age group.
Dr. Renuga?
Sir, for facial lesions, probably mometasone, extrafacials, focal lesions, probably clobetasol I'll prefer.
Dr. Vikram?
I think what I do, 2 months mometasone and next 2 months fluticasone. So I alternate these two drugs. They're safe drug. You can use it for long term. And many times I just give them weekly. I mean, only 2 or 3 times a week or sometime alternate day. I avoid them giving daily for a long time.
Dr. Smesh is around. I'm not seeing.
No, he left, sir. He has another meeting. It seems by 10 o'clock. So
okay. So one issue is like, do you give it daily? So any panelists would like to take on this, like how they.
Clobetasol I use only twice a week, because the drug disposition of clobetasol is such that it will remain bound there for 5 days. So yeah. 2 days plus 5 days, 7 days. 2 days is more than enough. Beyond 2 days, there are chances of atrophy being there. But with desoxymetasone, mometasone in small children, I again keep it 2 days a week. I don't give regular daily steroid. I've never it. Yes, in wherever there is need, there is more new. Where I think the disease is slightly aggressive, I might not use oral steroid, only topical steroid. There, for first few weeks, I might use 3 days or 4 days a week, not beyond that.
Actually, there is two types of schemes: the continuous and discontinuous. Continuous scheme once in a day for 3 months, whereas discontinuous scheme there is a one again once in a day for 6 months. In both, it will works.
Yeah. So this is how to give topical steroid. Then topical vitamin D3, again there is a debate. Some say it's effective, some say it's not effective, because they're very slow to act. If you have to see its effect, you have to be very patient. So, and moreover, it's not like topical steroid or TCIs. It behaves differently. So mechanism of repigment is different, which is very slow. So
See, I find them very effective. I find them very effective when I use them in methotrexate, and I find them effective on the acral areas where we have a risk of atrophy with topical steroids, and acral areas usually calcium inhibitors don't work that much.
Yeah. So any other panelist view on?
I usually use combined. I usually use combined.
Okay, in combination. Yes, Dr. Slim.
It should be a combination with a narrowband UVB.
Okay.
Dr. Renuga, works better.
Dr. Renuga, you have experience of using it? You have to unmute yourself.
But this narrowband with the vitamin D, it's not an ideal combination since what I heard. So
there is one study showing it's not to be effective, but we still see some good efficacy when we give it for long term.
No, it is with UVB and vitamin D analogs. There is one problem. You don't have to use vitamin D analog before you give therapy. First of all, you have to give therapy, UVB therapy, then you can use this. Otherwise, it gets detoxified by the therapy. So that is the catch here.
Yeah. So this, I just wanted to highlight here that all the cells are defective in vitiligo. Apart from melanocytes, keratinocytes and fibroblasts are defective. They are not secreting good growth factors for the melanocytes. So melanocytes are getting damaged. They are not able to survive in the absence of these growth factors. So we know this afamelanotide, which is alpha MSH analog, which is one of the most potent stimulators. So I think in India, we don't have experience of using, anyone has experience of using afamelanotide? It's very costly, but again, its efficacy is like it increases, it rather increases the rate of repigmentation with the phototherapy. It's given as 16 milligram subcutaneous monthly implant, but probably that after phase 3 trials, so the company has stopped the trial. So we are still waiting for next phase, like if it's coming into the market or not. So I think all the panelists, there was some question on this. Probably all of us has no personal experience of using this afamelanotide, and it's not available in India. So this is another decapeptide BFGF. In theory, this is very good because it can attract the melanocyte from the border. So it can even induce the repigmentation in patches with the leukotrichia, because it can attract the melanocytes from the margins to give rise to the marginal repigmentation. So I can just ask from Dr. Movesh, like personal experience of BFGF analogs, BFGF decapeptide in vitiligo.
The combination therapy works better, sir, rather than monotherapy. So if it is less than 10% body surface area, the decapeptides with the tacrolimus 0.1% will work.
Yeah, so recently we reported that combination of tacrolimus with PFGF. So Madam Lakshmi, your experience on this PFGF?
Yeah, yes, alone it is not working. It's only a combination. Whether it works or not, I'm not sure.
Yeah. So Dr. Bakaya, sir?
Yes, in fact, this drug is very good for the lesions like on the palms, soles, because there you are dependent upon the fibroblasts. There are no hair units are not there, so their melanocytes have to be stimulated factors from the fibroblasts. In these areas, it's very good, but again, in combination, it works much better. I use it for even mucosal areas. It works much better over there. But in combination, individually, I don't think it works much better. It works only in combinations. And
Yeah.
with the tacrolimus, it works much better.
Yeah, or with phototherapy. Yes, Dr. Slim, you have any experience of using this DACA?
Yeah, we've been using it, but I don't know whether it's really, I mean, certain vitiligo with the lips and areas we have been using with combination tacrolimus.
Yeah, yes.
Along with phototherapy.
Yes, Dr. Renuga. You have to unmute you. Please unmute.
I have not found it to be much effective, sir, individually. So I don't have much experience with BFG.
Okay.
Is it because of the when it is transported, it gets deactivated, or what exactly should be the?
Yes, theoretically speaking, it has I think, the best action on melanocytes, but probably it has to do with that it's not very stable molecule and something to the penetration, because it's a DACA peptide probably. So initially when we tried, we given even intra-lesional injection, and that results are very interesting. Dr. Vikrant, any personal experience with this DACA
No,
peptide?
I use only when nothing works for a small localized patch. But I'm really not fan of this drug.
Yeah, so we have seen in some of the cases, again, it's a slow acting, so we have to be very patient. So similarly, this prostaglandin analogs, again, they are tried in combination. Any panelists would like to take on this topical prostaglandin analogs like latanoprost, imatoprost? So we found it to be effective. Like
I started giving this prostaglandin analogs along with calcineurin inhibitors.
Yeah. Yeah. So combination again, but probably we are just relying on ophthalmological preparation. If we have a proper dermatological preparation with good vehicle, with good penetration, and that need to be washed. And I think one French company is interested in this, and they have started working on dermatological prep. As of now, there is no dermatological preparation of any prostaglandin. So that again would be a new thing to be watched. So as of now, we combine this combination. We have already discussed combination with topical steroid, TCIs, with all this can be there. We have already discussed, I think. So just this is very interesting, like how to maintain once we have repigmentation. So how to maintain? So we can have a just quick overview from the panelists, like how they approach the patient after completing the repigmentation. What are the strategy to maintain the stability in non-segmental vitiligo? We can start with Dr. Gumesh. Like there is a topical tacrolimus has been proposed as a maintenance therapy. So in our protocol, we follow this. After repigmentation, we ask the patient to apply
bi-weekly maintenance. We can give tacrolimus 0.1% bi-weekly.
So this is
and the assurance
patches. So we found it to be very effective. So this can be given for quite a long period. We ask the patient to apply it twice a week. So similarly, there are approaches like phototherapy as a maintenance. So any panelist has experience of using phototherapy as a maintenance when there is a successful repigmentation, just to maintain that repigmentation. Yes, any panelist?
We have been using even after repigmentation, we used to continue phototherapy as a maybe around one or two sessions in twice. I mean, in about 15 days time.
Yeah.
Initially weekly, probably once in 15 days, we used to ask the patient to come and get it done.
Yeah, yeah. So this diagram here, although looks quite basic, but here is the future. So this has almost accepted by this non-segmental vitiligo is unstable, because the cytotoxic cells, they remains there even after repigmentation, this CD8 positive. So what are the factors which retain them? This is interleukin 15. If we target it interleukin 15, so there will be no CD8 cytotoxic cells in the patch. So this is again going to be future therapy as a long-term stability. Like if there are two targets now, interleukin 15, and its receptor is known as CD122. So either this monoclonal antibody against CD122, or if we can directly block this will be the, again, very interesting molecule. So that's why I say this vitiligo research is in very exciting phase. So we are expecting some breakthrough.
Dr. Devinder, I have one question to you.
Yeah.
Dr. Devinder, I have one question to you. See, I have seen the role of vitamin D3 theoretically. Theoretically, it is important at three places in our. It can be important in three places. WNT pathway. It's important to maintain that pathway to maintain a good homeostasis of vitiligo. Vitamin D3 role is there. Drug cells. Drug cells to take care of the scars of the vitiligo, molecular scars of the vitiligo, vitamin D is there. Is there any research of vitamin D3 in vitiligo in our Indian studies that we have studied role of vitamin D3 in vitiligo?
Yeah, we do this topical one because vitamin D3, if the levels are normal in the body, so this is not going to have, to our mind, any much added efficacy. But this all mechanisms are for topical vitamin D3 analog like calcipotriol or calcipotriene when they act locally at the skin level.
So it can be used as a prophylactic. It can be used to arrest the disease as well.
This in our personal discussion also, when the vitamin D3 level in the body is normal, so as a therapeutic, adding more vitamin D3, how much is going to be effective is not that clear because it does not reach the skin at that concentration which is given by the topical vitamin D3 analog. So probably in that direction, we need to have some selective vitamin D3 analog, topical vitamin D3 analog rather than systemic. So I think among us is Dr. Salim has this focus area on. So we will not be going because already it's 10:15. So we'll just have just a basic question. So there are many questions on this, like what is minimum age when we can take the child for the surgery? Dr. Salim, your opinion on this?
Yeah, there is no, as such, there is no age limit. It's basically at any age you could do. But what we do recommend is like we do it only after around 6 to 7 years on, especially on a segmental or unilateral vitiligo over an exposed area if it has to be covered. Yeah. Otherwise, we don't. For bilateral vitiligo, usually in a pediatric age group, unless otherwise it's indicated, we do not do it because we do have a chance for recurrence again in most of those cases.
Yeah. So, Dr. Bumesh, you go for surgery for your patient?
In our department, selectively we will do, especially the stable vitiligo, the segmental vitiligo. In those cases, we'll go.
Yeah. So, I think any other panelists with interest in vitiligo surgery?
Because only in pediatric cases, I do is dermabrasion sometimes, that too, for a patch which is stable and which has got still black hairs. So sometimes, not very commonly, but sometimes I do. Otherwise, all other surgeries I avoid at least below 10 to 15 years of age.
Yeah, but as Dr. Salim mentioned, I think with the outcome is the best in this age group. So only concern is like some even dermatologists, they are aggressive, they go under general anesthesia but we don't, that aggressive, but we wait for that age group and we can just counsel the child because the procedure is not that sort of painful, but we need a sort of cooperation from a child. So this is not a fixed guideline exact, like it's a 3, 4, 5 or 6, but depending on in which age group which you are comfortable in handling such a child. So we go even for non-cultured epidermal cell suspension, which is sort of uh, show a very good result as we see in adult subject. So now we have some of the questions which still remain unanswered. So there is one question on levamisole. So any panelist who use levamisole as stabilizing agent?
In fact, I have used levamisole for almost 2 decades as a stabilizing agent for vitiligo. But I have stopped it almost 10 to 15 years back because I used to get a lot of patients of agranulocytosis. After every 2 to 3 months, I had a patient who would come with the low counts. So with so much of low counts, every patient coming after 3 to 4 months having low counts, because I used to monitor them every 2 to 3 monthly, but they used to have low count, so I stopped using levamisole. I got frightened also because in 1 year I saw 5 patients of leukopenia because of levamisole. I stopped.
What was the result, sir?
But
How
does
was,
it work, sir?
Hi, madam.
What was
Does
the
it
results
work?
like? Does it work?
No. The result, see, you have to realize that vitiligo, you don't have a result 100%. But the patients who were very well maintained, and I had to stop them. I could not give them because I could not continue because leukopenia occurred in them. The patients were okay. The patient did not go into a granulocytosis, but the counts came back within about a month or so. But I was frightened. I can simply admit that I got frightened. I did not write. For first 2 decades, it was okay. Probably the type of the levamisole which we are getting was not good. Actually, levamisole has a problem. It has 2 isomers, D isomer and L isomer. What was said that previously L isomer was very good than the D isomer. In initial stages, we used to get both isomers, L and D, but in the later stages, L started being supplied less. So we used to rely on D. I think it was D which gave me the problem. I never used then D also. L isomers were good till they were freely available.
Yeah, but looking at evidence base, because one very controlled study from AIMS, they've shown it's just like a placebo. Initially, I used to prescribe like lot of levamisole in initial stages in slow spreading vitiligo, but like for last 10 years or so, I've stopped prescribing levamisole as stabilizing it. I think
So
the
have
other panelists also agree.
So have I.
Yeah. So there is one, yes, Dr. Bhumesh, you can take on this, the topical preferred treatment for 3 months old child. So which is the topical treatment in a 3-month-old infant?
If it is focal vitiligo, if it is on the face, we can go with the fluticasone. If it is an extra facial, we can go with the mometasone for a alternate day therapy.
Yeah, I have seen some of the dermatologists prescribing like 0.03% tacrolimus in vitiligo. So can
It does not work.
See, it won't work.
It does not work.
0.03 is just like a placebo and equivalent to the moisturizers.
So we want to highlight here, like tacrolimus, it has to be used as 0.1% in vitiligo. That is the minimum.
Because molecular weight is big. So in a compromise like atopic dermatitis, it's may. But in a vitiligo, no.
So that is why there is a role of even occlusive. Sometimes there are a few studies where they have shown that tacrolimus under occlusion works better, probably for a better absorption, for better concentration. So probably we need a higher because it is for atopic dermatitis, as Dr. Bhumesh mentioned, for compromised barrier. But for normal skin, we need little higher concentration. That would be very effective because tacrolimus is a potent stimulant of melanocyte proliferation as well. So that could be a good agent. So another question is on...
What about pimicrolimus? Devendra Prasad?
Yeah, same.
What about pimicrolimus?
Pimicrolimus comes in the same, that one concentration. So probably efficacy-wise...
Is it less efficient than tacrolimus?
So,
but tacrolimus, first 6 months of age, no. But pimicrolimus, even as per Pittite study, they have conducted a study of 2,500 children from the age of 3 months that can be initiated from the age of, now the Pittite study it is approved.
Yeah. So, but efficacy-wise, it may be little inferior to the tacrolimus.
Yes.
I mean, it's not as comparable as to tacrolimus.
Yes.
So there is one more question on apremilast. So anyone has experience on using apremilast as a stabilizing agent in childhood vitiligo?
No idea. I have never used.
Yes, we did try in adult patients, but we have, I mean, in our experience, it's not effective even in stabilizing. So probably it's not going to be a good molecule to be watched in a near future. So one question was on use of BFGF decapeptide is a safety in children. I think all us can say it's safe that way.
It's quite safe
in a
not age.
Yeah.
In fact, in pediatric age group, it is easily applicable by even in the genital area.
Yes.
And after then sun exposure, and especially if they can take on terrace and they can keep for sun exposure for 10 to 15 minutes.
Yeah. So we can take this last question probably. So is experience of 5FU with needling or dermabrasion. Dr. Slim, probably you have
In
some
children,
experience.
we don't use it, sir. Adult, we have tried, but in a child, I don't have any personal experience with the 5-fluorouracil with the needling or rollers, derma rollers in children.
Yes.
Uh,
Dr.
five
Sir,
Fran,
I have done. It is
Please.
actually good. The pigmentation is much better with 5FU. We do microneedling. Above that, we apply a 5FU ointment and put a clean film over it. It actually, the pigmentation comes very faster.
5FU could be a good putative drug for the areas in acral areas and in hairy areas where it can be used very effectively. But unfortunately, we had one thesis from PJ Chandigarh that was long back, and in I think 1988-89,
yeah.
Murlidhar Rajagopalan had done it. But after that, in the last 2 decades, I have hardly seen any papers on FU in 5FU in vitiligo. But it is worth a try in areas where there are no hair. It can be used in acral areas. With microneedling, it could be a good agent. And I have started using for the last 4 to 5 months FU in few of the patients. I have not seen that much effect in the follow-up after 3 to 4 months. I'll try for some more time. But 5FU supposedly has to be good, but with microneedling, it might be better.
Yeah. So now we are getting questions which has already been covered, like best treatment for fast progressive vitiligo, so which steroid in pediatric age. I think we have already covered. So I think this is a time to thanks my esteemed panelists for such a wonderful discussion on a vitiligo, a disease which is very close to my heart. And I thanks all panelists, Dr. Bumesh, Dr. Ma'am Lakshmi, Dr. Pakaya sir, Dr. Slim, Dr. Renuga, Dr. Vikrant Soiji, and Dr. Sumesh for joining us tonight for this elaborate session on childhood vitiligo, and hope we have contributed and we have solved many questions surrounding this topic. And I thanks Mr. Halder and Alcom team for organizing this webinar. Thank you very much.
Vote of thanks by Mangrish. Mangrish.
Yes, sir.
Yeah.
Yeah, I'm there, sir.
Thank you very much.
And we thank all the delegates, almost 700 plus delegates they have participated. Thank you very much for your valuable time.
Thanks. Respect doctors, good evening. And on behalf of Alchem Dermatology, I take this opportunity to propose vote of thanks to all our doctors who attended today's excellent interactive session. At the outset, I thank all the expert panelists and our esteemed speaker and moderator for enriching us with their knowledge and experience in childhood vitiligo management. With these warm words, we move to the end of the session today. Thank you and good night to all doctors. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks all.
Yeah, thank you, Devendra Prasad sir, for nice moderation. Excellent.
Yes.
All take-home messages. Thank you very much, all the panelists.
Thank you. Thank you.
Thank you, sir.
Thank you.
Rahul, stop the live feed.
Yeah, Mangrish.